Good morning, everyone. This is Kelly Sheets with DMS. I believe it is 8:30, and we do have a quorum, I believe. I have Dale, Cresta, and Linda on. Am I missing anyone? Okay, that does make a quorum. I'd just like to remind everyone, for the members, if you will be voting, you need to have your camera on in order to meet open meeting laws. So with that, I'll turn it over to you, Dale.
Thank you, Kelly. Good morning, everyone, and welcome to the Kentucky Medicaid Therapy TAC meeting. The first thing on the agenda is to review and approve the May 12th minutes. Has everybody had a chance to read those? And
Everything looks good, Dale.
want to make a motion to
Yes, sir. I'll make a motion to approve.
hey. Linda? I guess we need to vote on that. Hey. Morning, Emily.
Good morning, everyone.
There's not a lot of business on the agenda today, but mostly old business. The first item on the agenda is a follow-up from the Department of Medicaid Services. What are the department's study findings on increasing the OT, PP, and speech fee schedule? Just wondering how the progress is on that. Anyone from Kentucky Medicaid like to speak to that?
I don't believe anyone from Medicaid is on that could speak to that. I can certainly take that back and ask for a follow-up.
Sounds good. I was under the understanding that we're going to try to have that study completed by mid-July. Just wondering what the progress is on it.
I'm currently on here. This is Cynthia Toll. I will need to take that back to Justin and find out from him exactly where we stand on that, because I'm not for sure.
Okay, thank you, Cynthia.
Can we have an update on that before our next TAC meeting?
Sure.
Okay, thank you.
I will do my best. Let me just say that.
Sure. We just kind of want to know like where it stands, because I know you all had to submit all the information to the governor and whatnot. So
this is Jonathan. I believe that we have submitted that. That may have been a different report that we submitted, but I think that is going through the process and should be submitted to the LRC in the next couple of days if it's not already there. But I don't know that we have a version we can share with you today.
Sure. Great, Jonathan. Thank you. The second old business on the agenda is a follow-up on personal Medicaid requiring physician signatures on the plan of care. I think Justin was going to respond to that sometime in the last 2 months, but I haven't heard from him about what Medicaid's interpretation of in collaboration with. And
Hi, this is Kelly again. Justin is entering the meeting right now. I just admitted him, so as soon as he gets connected, he may be able to address that. Justin, we're on number 2 of the agenda, and they have asked if you could address that.
Absolutely. So This is Justin Derringer, Acting Director, Division of Healthcare Policy. Yes, that one is complete. We're finalizing the provider letter for this, so we will be sending that out hopefully this week, if not this week, next week. Anytime we send out a provider letter, it has to go through some processes, but you all will be receiving a provider letter that goes over this either this week or next week. So, but we have came out with a opinion based on our interpretation of the administrative regulation, the way we created it to read for this, and it will be, I think, allow for a standard of for everyone to be able to use it the same way.
Okay. Look forward to seeing that letter, and hopefully this will ease the burden of getting prior authorizations with Kentucky Medicaid. It's quite a burden to have to get a physician signature before we submit it to a PA. Often we have to actually take the plan of care to the physician's office to get a signature. And
I think it will definitely ease some burdens. So
glad to hear it.
Justin, since you gave us an update before, you any chance have an update on the submitting the fee schedule? Information?
yeah, well, no, only that it's still in process. So as you all know, we enlisted the assistance of a couple of contract agencies. They've still not completed their assessments yet, so we're still waiting on them to get back with their finalized reports before we can assess their data and make a determination.
Okay, I was under the impression that it had to be in the governor's office in July.
So that the report that was sent to the governor's office is it doesn't accomplish the goals of what we're trying to accomplish. It accomplishes the goals of what the legislation asks for, but not specifically what we're trying to do with, which is look at every single CPT code for every single therapy type, provider, service, from all different providers. So, you know, we have school-based prices, we have waiver prices, we have EPSDT prices, we have regular, providers pricing, and then we have places like PPCs and other places that provide therapy too, that give even different rates. So all those things are being looked at, analyzed, evaluated, compared to other states on what their CPT code pricing is compared to Medicare. So it's an in-depth process that they did not have time to complete by that process. They didn't have time to complete. Now they completed what was required of them by the statute, by the bill, and have sent that to the secretary's office for review, and then sent that in. But that doesn't really have much bearing on this particular project that you all are talking about, the one that's going to determine what we do with rates specifically.
Okay. Thank you.
You're welcome.
Dale, can you let Renee in? I think she's trying to get in.
Hi, yeah, she's not in the waiting room. I got that email. She is not showing it in the waiting room. I'm gonna respond to her and ask her to maybe go out and try again.
Okay, thanks.
Sure.
Justin, this is Emily. I'm assuming that within that project, we are also reviewing sometime therapy CPT codes in relations to the wound care codes. There are several providers in our state that provide Medicaid services for wound care. So I wanted to make sure that those rates were being addressed as well.
We do have those rates. Anything that is billable by our providers, and anything that's billable by other states' providers. That's part of what we're looking at too, is, do we have everything we need on our fee schedules?
Okay, I appreciate that. That's a niche that sometimes gets overlooked. So thank you for including that.
Okay, thank you. We can move on to the third item of old business. It's a follow-up with referencing the regulation the department used as a guideline when they permitted Evercore to create their own medical necessity criteria. I got a response, I think, from James Gerald's, or we did, that TAC did it after the last meeting, that it wasn't relevant to that. Whatever the regulation is there some exact wordage in the regulation that would allow the department to let Evercore create their own guidelines.
I don't have an answer for this one today. I'll have to see where we're at with that one and get back with you. I'm not sure. I wasn't working on that one. So some other people were. So I'll have to check in with them and see where we're at with that and get back with you.
I appreciate it. You can try to let us know in the next couple of weeks.
Yes, absolutely.
I appreciate it, Justin.
Yeah, sure. The number one agenda item, I don't have a time frame for it. Number two will be within the next 2 weeks for sure. You'll have that, and then I'll get an answer for number 3 in the next 2 weeks also. And since we're talking about it, number 4 is going to be on that same letter that goes out to you all. The answer for the guideline from us for that will be on that same exact letter. So it'll be a 2-part letter.
Yeah, that's great. It's the NCOs have a different criteria for getting prior authorizations than Medicaid does, and so when you have to try to get it retro, whenever a member flips over back to traditional Medicaid from an NCO, it's tough to get that authorization.
Yes, sir.
I appreciate it.
Not a problem.
On the new business, the TAC just has a question regarding the new authorization portal. Has there been like beta testing done for that portal, or before it goes live?
Is there anybody else from Medicaid that would like to speak on that? Probably not. So they're having a team meeting currently as we have this TAC going over some of these some of this testing of the portal. And so there's multiple phases of that. I'm not sure exactly where they are in their trial period, or if they're going to do any kind of testing for providers before it actually goes live. So I don't know for sure. I'd have to find out if they're going to do that or not.
Hey Dale, this is Pam Marshall. Can we request from the therapy TAC that there be some kind of trial, especially for our type of prior authorization, since we're a little bit different than some medical practices, meaning a lot of times some providers are just getting like a one-time PA for a one-time event, and our PAs impact the child weekly, and it would cause us to have to put children on hold and disrupt their services. So we just want to make sure that's not going to happen, that all things work smoothly. And, I was around during the expansion of Medicaid in 2014, and the whole process back then didn't work to even get a PA, see a patient, get paid. Like there were so many things wrong with the setup that I think it would maybe just prevent some problems if we could beta test it or make sure, you know, all the therapy types, it works before it goes live.
So that's a great suggestion. I'll definitely take that back and see, you know, anytime there's a new program, there's an amount that's budgeted, a budget that's allocated to that. And so the software developers will, you know, any amount of time that's spent in development is a time allotted in the budget. So we have to make sure that we have enough funding to do that and time to do that and all those kind of things. But let me see what I can find out and get back with you.
Well, and the other suggestion is there not a way to set up, you know, mock or fake patients and just let us try it with Medicaid employees versus the software employees? I don't know how all that works, but
Right. Yeah. And I think that's kind of, you know, one of the tools that they use when they're designing things. I mean, they'll have our employees go through it with, you know, Jane Doe, John Doe type patients, but then they will, you know, sometimes they'll open that up to providers to do as well. Again, I have to see how this contract was set up and written and how much money and time's left in it.
okay, because I guess we would love to join the Medicaid employees if they are doing that sort of thing, because sometimes having the eyes of people who actually provide the service, we can spot the problems if there are any.
Absolutely. Let me see what I can find out. But I understand.
Thank you, Justin. Are there any other issues from TAC members or the public that's on this call?
I have a question, I guess for someone from Medicaid. Poor Justin, you're in the hot seat today. So I don't know if you can help or somebody else can, but it's about the tracking of no-show visits. So you all have a portal where we go on and putting the information in. So I'm just curious, like how you all are using that data. We had discussed it a little bit before, but it was, I guess, they're fairly new, or there wasn't a lot of information. People weren't really putting a lot on there. So I don't know if that had improved, if there is more, people are putting more information on there now, but each entry takes several minutes. You know, so we kind of figured it up, just did like a random week, and it's taking our administrative staff about an hour and a half or so, you know, to enter that stuff in every week. And we have, you know, some things in place, and we don't let those carry on. But when you have a pretty decent sized Medicaid population, obviously that, you know, impacts your practice a whole lot. We have no recourse. Obviously, we can't charge them anything. So I guess our question is like, what's being done with the data? What's the plan for, you know, is there going to be any kind of you know, what's the word I'm trying to say? Are the families going to have any consequences, I guess, for, you know, those no-shows and those visits that we just have nothing, you know, get nothing. So do you have any updates or anything on that?
Yeah, so one of the number one issue we talk to providers, especially when we have issues of areas where we don't have access, where we don't have enough providers in the area to provide the care that's needed for the communities. The number one issue is no-shows. And so in order to combat that, that no-show portal is really our main source of information. It's the main source of how we determine where we put our money, where we put our energy, where we put our efforts. And you know, it's not being utilized. And I understand it may be time consuming, and maybe we can find a way to cut down on the amount of time it takes to enter information into that portal. There's also a dashboard that's being created, should have already been created, but it's being created to show no-show data. So it'll be a website. You'll be able to go on a website. You'll be able to see by provider type, by county, no shows, reason for the no shows, things like that. Hopefully that will help increase providers using the no show portal. In addition, we're reimbursing for community health workers that may be a beneficial and contacting individuals that don't show up and finding out reasons why they're not showing up and helping them coordinate transportation or other things that they may need for appointments. But our goal with that portal and what we do with it currently, and what we're hoping to do with it when more providers become invested and start using it, is to see what reasons individuals have for not showing up. What are the no-show reasons? I understand there's going to be a percentage, maybe a large percentage of individuals that because there are no consequences, they just don't show up. And there's nothing that we as the Department for Medicaid Services can do about that currently. That's a decision that has to come from the legislature or the governor's office. But what we can do about that is all the other reasons, right? If there's a transportation issue, if there's an issue of them not understanding when the appointment is or how to call and reschedule the appointment, if there are other issues that are causing them to have no shows, we can attack and address those issues and shrink that percentage down to where it's a manageable number for providers. And it's not the number one reason providers aren't enrolling in Medicaid services.
Mhm. Yeah, I think there's a variety of reasons, but I think all those issues you mentioned, I mean, transportation, all the kinds of things come up, but at the end of the day, are they going to be super motivated to get there? Because what difference does it make, as far as they're concerned? There's not like a monetary, unless, I mean, you've got families that are, very committed and, they care about getting their kids there and that kind of thing. But it's just easier to say, oh yeah, we'll just, miss this one, whatever, or they'll forget that they won't call at all, obviously. But, there's lots of things that we try to point them, resources and things that we try to point them in the direction of too. And I know that you all do provide certain Medicaid plans are offering transportation services and things like that. So we share all that information with our families too. So, most of the time it seems like it's questionable reasoning why they haven't shown up. So, which, like you said, I don't know that there's a whole lot that you can, you can do, but maybe the governor or somebody else can do something with that. But okay, well, I'm glad to know that it's being looked at. So.
Justin, there's a question in the chat. Does an attendance policy for the facility go against any Medicaid program?
As long as an attendance policy doesn't involve billing a patient, traditional fee-for-service Medicaid does not have any other requirements or limitations. That's my answer.
That sounds reasonable.
That's fee-for-service Medicaid. So any contract with MCOs may be different.
Would any of the MCOs like to speak to that as well?
This is Stuart Owen with WellCare. Yeah, and the problem is the federal Medicaid rules prohibit, like Krista was saying. The reality is there are no consequences. There's nothing we can do. There is, this wouldn't tell you why. There's an ICD-10 diagnosis code, which would be easier to report, on a claim. That wouldn't be as time consuming probably. And it's for patient left without being seen. Of course, we're talking about a no-show, but that would be easier for tracking, but then that's not going to get to the reason. But, I really think the reality is just like what Chris just said, like something came up, they just don't think about it and there's no consequences, or they just, we've heard that, of patients just canceling and getting text reminders day prior, morning of, and then not showing up. And I honestly, there's telehealth now. they have transportation that's available. I really don't think it's that. But it just comes down to federal rules prohibit any kind of consequences. And I understand that. I mean, you don't want to charge a fee, to a Medicaid member for something like that, but I don't know. I mean, there is that ICD-10 code that could be a possibility for just tracking it, easier, but it wouldn't say why, because most of the time they don't give a reason anyway, but it'd be easier to put that on a claim.
Could you use that though, if they were never in the facility, because it says left without being
Right. Yeah. I mean, yeah,
there?
it's technically that they were there and left. That's the only thing. There is nothing for no show, and there's no CPT code, because it'd be nice if there's a CPT code. Yeah, if even it didn't pay anything just to track it, but there is none. But yeah, I mean, you're right, Linda. They technically it's that they left. And I don't know how often that happens. Probably not very often.
Usually only if they vomit.
No. Vomited and left.
That's when we make them leave.
Now, this portal that you were talking about, we actually have not been using that portal, but so that tracks actual no-shows where they just don't come, but it also will track put the cancellations in there if they actually called and gave a reason, correct?
Yeah, you're talking about DMS's portal. Yeah, and providers manually enter when they get a no-show and why, if the member told them why, the reason why.
Because what's really sad is like some of these kids that we're seeing, that are the chronic no-shows, then you'll call and tell them, you may have to discharge them. Then all of a sudden they'll show up that one time, then they'll go 3 more weeks. And what the very sad situation is these kids need it. I said, and the parents aren't bringing them for various reasons. So that's what's sad. You hate to discharge them because, they really need it, but you can't keep them on a schedule and take up spaces for those kids that will come also. So it's just a sad situation.
Yeah, and the ones who hurt even as far as providers, even worse are the non-emergency medical transportation, because they actually drive to members' houses and they like, I'm not going today. So they've actually, gas money or whatever. And I mean, I know that happens as well, that, they make the appointment, they show up, I'm not going.
Yeah, we track all of our no-show reasons, but we don't have time to put them on the portal. I mean, last week we had 167 no-shows out of, I don't know, 6,000. Man that, and so our data, I was looking at just no-show reasons. I mean, it's crazy, but there's a lot. So we don't use the portal, Justin. So I don't know how we would have time. And an example of that is, I'm fighting right now with Humana Medicaid, which is an issue I was going to bring up with Dale on the next point when we're ready to move forward. But this is an example of why I'm not able to put in no-shows or track some of those other things. With Humana Medicaid, they said that we had some providers that weren't showing as registered, and they took over 1,000 claims back from APT. Now, when we called, they said, oh, this is probably an error, which it was, but they took back 1,000 claims. Now we have to wait another 90 days to get paid that again. No problem on our end. They said this is happening to multiple providers. I wanted to see if this happened to anybody else. But that's an issue of what we're fighting, Justin, of consistently working with different MCOs that are pulling back money and claims, and then they're like, oh, this is an error on our part. I'm sorry, we will fix it. It's just going to take 90 days to fix it.
Hi, this is Samantha Harrison with Humana.
Yes.
I haven't heard anything regarding this. We would be happy to work with you on that if you can contact us to address that situation. it may have been through a financial recovery related to encounters that were rejected, but let us look into that for you and see how we can move that forward.
Yeah, we actually made a complaint with DMS 2 weeks ago and Justin haven't heard any response on that regarding who we've been in contact with. So Samantha, I'll find out who we've been working with on this and let you know here in just a few minutes.
I appreciate that. I'll put our compliance email box in the chat and you can reach out that way. Does that work?
Yeah. The person we talked to said this was happening to multiple providers from Medicaid, from Humana Medicaid. So it is just I'm just saying this is an example of administration burden, which is causing us a lot of headache and manpower. And therefore we're not able to track other things like the no-shows. And I just want to make sure that it's noted.
Yeah, Renee, it's happened at our practice also.
Okay.
Take backs from Humana that actually they hadn't taken anything back, but they said they were, and it was totally unjustified. And when we communicated with them, they said, yeah, that is a mistake. So, but it was take a while for us to get it resolved.
Renee, it's Pam. I think we've had a few as well, but we were on it pretty quickly and resolved it. But yeah, I think we've had.
Yeah, we were on it pretty quickly too. The issue was we had 1,000 claims because we have such a large provider network. And so because of that, now they're like, oh, it's another 90 days, or it might be 60 days now. I don't know. That's just the frustrating piece. So we did make a claim to the Department of Medicaid regarding that, but we haven't heard back anything, Justin. So I was wanting to talk about the timeline of when you make complaints. What does that process look like to make sure, we're following, as you guys tell us, here's the regulations, this is what we should do. We're working, everybody's tired. We haven't got an increase. I'm apologizing. My link wasn't working, so I didn't get to hear that update on if you had good news or not. But I think we're just all getting really frustrated and burnt out at this point.
Sure. Is there anybody on from the MCO branch that would like to talk about that process or MCO division?
Justin, I don't think anyone's on.
Okay. Okay. So I don't know the exact process. That's not my division, but I will have somebody reach out. Probably the best way to do it would be reach out to the TAC, send it to the TAC, outline the process, and then they can kind of send it out and let everybody on here see what the process is. So I think that would be a big plus for everybody to kind of see the steps and processes that they go through. You have to remember that those complaints are coming from every single provider type for all the MCO. So there are a lot of those complaints that they are getting, and it's not a huge division, but they can let you know kind of time frames and roughly the exact process and rough time frames anyway, so you have an idea.
And
One of the comments that was made was when they go to file a complaint. So when my revenue cycle manager goes to file a complaint, it only is for one claim. So again, she has 1,000 here. So what she did was in the comment section put that it was related to multiple claims, but that's also an issue on, just making sure if you're updating the portal or something, just know it doesn't allow you to put in how many claims or multiple claims. There's a comment section, but I don't know how much that helps there. Because you have to put in a claim number for one claim, not multiple.
I would agree, Renee. We file quite a few complaints, and usually the issues like Renee's company experienced are not our errors, not the provider error. It's a system error in the MCO. And it's challenging because we have so many MCOs, and you can have projects with every single MCO going on. So when there's another one like this issue with Humana, it's just a compiling effort. It's compiled on the provider, meaning we have multiple projects with multiple MCOs going on, and it just causes that much more non-payment. And I think that's our issue as a provider when we don't do anything wrong. And it's some system error like this that's kicking our providers out, paying out a network, then it's just a fight to get all of those claims paid and in full. And anytime you have a project, there's fallout from the project and you have to follow those up. And so there's not a lot of support on the provider side to have to wait to get paid 90 days after a recoupment that you did nothing wrong seems unacceptable as a provider. It's just because, what happens is we, the little provider, have to go borrow money and pay interest on that. And then we don't even get paid interest half the time from the MCO. It is, I wish there was a better recourse, a better way that prompt payment could be enforced in a situation like this.
It is problematic and costly.
That's all I had.
Any other issues that the TAC or the public like to speak of?
Renee, you said you missed the update on the
Yes.
the stuff. Yeah, there's no new information other than whatever needed to be submitted to the governor was submitted, and but the Department of Medicaid is still working on, I guess, the more detailed aspects of it, because they're doing specific codes and their rate recommendations and all of that. So that is still in process, that part of it. But the other part that was due in July, my understanding is that was submitted, right? Justin, did I sum that up pretty basically? Okay.
That's exactly correct. Yes.
Okay.
And I wish we had it in the budget to just do a broad increase percentage wise, but fiscally that's not, we there's no way we can do that fiscally. So we have to look at each code, and codes are very different. So to be fiscally responsible, we have to look at each code, because some codes are above what what our averages are out there, and then a lot are below. So we can't, we have to take those individually, and it just takes some time, but we're getting there. I know it's frustrating, but we're getting there.
I know this is probably completely a guess on your part, Justin, but is it likely, unlikely that we will actually see this update before the end of the year?
I couldn't speculate. I don't know the answer to that.
Okay.
I did want to bring up one issue. If I don't know when it's time for me to do that or not, but can I bring something up really quickly?
Sure.
So I had mentioned that provider letter that's going to go out, that's got 2 of the issues on there. It's actually has a 3rd issue on there that I wanted to make sure that you all are kind of aware of. So for outpatient therapy assistant billing, CMS has sent us guidance that we are required to follow. And so we will be sending that out with claims that are billed for outpatient therapy services are going to be required to use a CO modifier when they're furnished by OTA or CQ qualifier or modifiers when they're provided by PTA. So and we have that kind of broke down for you in that provider letter also. So it's going to be a fairly, I guess, maybe a three-part letter or 3 separate letters. I'm not sure exactly how they're going to do it, but I mean, the way I sent it up was a 3-part letter. So If they choose to break that down on upstairs, then maybe, but
Justin, it's Pam Marshall. Wasn't that that was put out by CMS a couple years ago, so I would assume everybody should be doing that. Not sure if everybody follows the rules, but that,
yeah, not everybody's been doing it. I don't think so.
yeah, it's been
Just
for
kind
quite a
of
while.
a clarification because we just changed the system that it will require it. So anytime we do that, we have to let you all know so that when you bill differently, it's not going to pay.
Yeah, I think that modifier was addressed probably 2-3 years ago, like Pam said, so people should already be doing it, but it's a good idea to remind them to do it.
Well, anytime we make a system change that eliminates things that people have been doing, we always have to let you all know. So
Yeah. And I'm not sure, I don't know if the MCOs can speak to this, but have you all, MCOs, have you done audits on that issue?
This is stored on with well care. I do not know. I don't recall, but that's not where my day-to-day responsibilities are. So I honestly don't know. I can check if y'all would like.
Yeah, I'm just curious if that is a problem, and I would suspect the only way you would know it is if there's a high number of claims for one OT.
Yeah, and I mean, I have not heard of that. So I'm kind of thinking it's probably not a problem.
Or it's not been looked at because, you know, claims would be billed under an OTR or under a licensed occupational therapist for a CODA. And so you may not know unless you audited and saw that the CODA's name was on the note, but the OT was on the, you know, the only way to pull that is if there's a high volume of claims for an OT. Like an OT typically doesn't see much more than around 30 to 32 patients a week. And if they had a higher volume, then, or a PTA, then you would know that they had assistants under them.
Yeah, I definitely have not heard of us like pulling medical records to audit for that.
Okay, any other issues?
Renee, you're muted.
Sorry, I'm having to use my phone versus my computer, so it's hard to move it. So Justin, I just had a question. So since I've missed parts of the first of the meeting, which I'm really sorry, the letter that you're referring to, which yes, I agree with Pam, we do the same thing with our codes on the modifiers. We've already been using those, but was there new information on that letter going out? And if so, you don't have to go over it, but when is the letter going out so that we can look at it?
it will be out this week or next week for
Okay.
sure.
Okay, all right. Thank you.
Okay, I don't suppose there's any recommendations for the MAC. Offenders. So the next therapy type meeting will be Tuesday, September 12th. Thanks everyone for attending and all your updates.
Thank you, guys.
Everyone have a good day.
Yes. You guys.